Hello viewers, welcome to my channel. If this is the first time you're clicking on my video, hello, I am Puspen Dasgupta. I am an ENT specialist from India and I upload videos on YouTube at 9 p.m. Indian Standard Time on each day of the week. And each day of the week, my videos follow a particular theme. The theme for Monday, that is today, is MS ENT. During my post-graduation, as well as during my tenure as an assistant professor, I identified that it is quite difficult for postgraduate ENT students to come up with 10-mark answers that they have to write during the theory exams. Often, answers to questions are not found in the same textbook, so they have to do extensive research before their exams to prepare adequately for the theory exams. This is my attempt at making their job slightly easier by preparing answers for the commonly asked questions in theory exams. So today's topic is orbital complications of functional endoscopic sinus surgery, and I hope you will like this video. Stay tuned. A thumb rule that I used to follow while writing answers to theory questions is if it carried 10 marks, I would write 10 pages. You are free to ignore this advice, but it helped me. So the question is orbital complications of endoscopic sinus surgery. In the first page, it is a good idea to list the common orbital complications of endoscopic sinus surgery so that you can refer back to this page when you're writing the answer. Also, please don't devote more than 15 minutes to each question. I know it is difficult to write a 10-mark answer in 15 minutes, but that is why you should practice repeatedly. So here I have listed out the common orbital complications of endoscopic sinus surgery: nasolacrimal duct injury, periorbital ecchymosis, intraorbital hemorrhage, extraocular muscle injury, periorbital emphysema, and optic nerve injury. I will describe them one by one. I will describe the injury, how it can happen during endoscopic sinus surgery, and how we will try to manage each complication. Also, it's a good idea if you remember to mention some statistics related to how often orbital complications are seen following endoscopic sinus surgery, that is less than 1%, and how many of the complications of endoscopic sinus surgery involve the orbit, that is 16 to 50%. So while only in about 1 in 100 endoscopic sinus surgeries orbital complications are seen, if complications are seen following endoscopic sinus surgery, 16 to 50% involve the orbit, because as you know, the orbit or the eye socket lies very close to the nose. So let's discuss each complication one by one. Here we have nasolacrimal duct injury. Nasolacrimal duct injury can happen in one of the two steps of endoscopic sinus surgery, or it can happen in both steps. One step is uncinectomy, that is removal of the uncinate process, or when the maxillary antrostomy is being widened anteriorly. The management of nasolacrimal duct injury depends on the timing of the diagnosis of the complication. If it was diagnosed intraoperatively, you can go for watchful waiting or planned frequent irrigation to prevent fibrosis and subsequent stricture, or you can go for definitive management, that is endoscopic dacryocysterinostomy. However, if you diagnose nasolacrimal duct injury postoperatively because the patient developed complaints of epiphora, that is frequent watering from the eyes, then the management remains endoscopic dacryocysterinostomy. Endoscopic dacryocysterinostomy can be done while performing endoscopic sinus surgery because it is also an endoscopic procedure and it does not require a fresh incision. Let's discuss periorbital ecchymosis. Periorbital ecchymosis may signify bleeding from anterior ethmoid artery or posterior ethmoid artery, or it can also be due to fracture or dehiscence in the lamina papyracea. Lamina papyracea, as you know, is the medial orbital wall. It is a thin bony plate separating the eye from the nose. How do you manage periorbital ecchymosis? If there is a vascular mishap, like there is a blood vessel injury, you can try to cauterize the artery or ligate the artery. If there is no vascular mishap, then the treatment is conservative, where you instruct the patient to avoid blowing their nose for 1 to 2 weeks after the surgery, and you can also start broad spectrum antibiotics for 1 week. The next complication we talk about is intraorbital hemorrhage, which is probably the most important complication of endoscopic sinus surgery. Now, hemorrhage can be venous, it can be arterial. If venous, then the hemorrhage would be slow. It can lead to spontaneous hematoma. It will produce lower intraorbital pressure comparatively, and it can be traumatic. Arterial hemorrhage may be iatrogenic, may be traumatic. It will have a rapid onset and it will produce higher intraorbital pressure. The most common reason for orbital hematoma following endoscopic sinus surgery is complete transection of anterior ethmoid artery and ensuing withdrawal of the artery into the orbit. Now, some of you have told me that you can't read my handwriting, so I am reading what I've written. And also, the idea is not to duplicate exactly what I've written. You can come up with your own answers. This is just a sample answer. I'm sure you can come up with better answers on your own. The reference for this particular answer is Scott Brown 8th edition, and you should use good references as well. So if you have identified this complete transection of anterior ethmoid artery, then you should treat it as soon as possible, because this can help in prevention of irreversible and complete visual loss. So a person can completely lose their vision in one eye irreversibly if this is not treated immediately. But in the quest of treating this condition immediately, you should not make the mistake of trying to cauterize or catching the bleeding vessel within the orbit, because this can lead to worsening of the scenario by traumatizing intraorbital structures. So how do you manage it? There is a management algorithm for orbital hemorrhage. If you are suspecting orbital hemorrhage, the first thing you should do is inform an ophthalmic surgeon. Then you should elevate the head end. You should try to remove the nasal packs or keep minimal nasal packs. Then you should start something like acetazolamide or mannitol in appropriate dosages, systemic steroids, and topical vasoconstrictor eye drops. Then you can go for something called lateral canthotomy and or inferior cantholysis. Then you should perform a check. What should you check? You should check the pupillary reflex, retinoscopy, and tonometric pressure. For this, you need an ophthalmic surgeon at the bedside. This is why ophthalmic surgeon should be informed immediately. If this check turns out to be normal, then you can continue the same management, or you can stop and closely follow up the patient. If this check proves to be abnormal, then the next surgical step is medial orbital decompression. Then you perform the same check again. If the parameters are normal, then you can stop the treatment and go for close follow-up of the patient. But if the parameters remain abnormal, then the next step is inferior orbital decompression by the sublabial approach. And even if this fails to control the pressure, then you can go for external orbital decompression. The next complication that we talk about is extraocular muscle injury. This is typically due to improper handling of instruments. So it's very important to handle instruments properly. What is the presenting complaint? Patient usually complains of diplopia, that is double vision, and the muscles commonly injured are medial rectus, much more commonly injured than the inferior rectus. Now, the different stages of injury can be identified by performing gadolinium-enhanced magnetic resonance imaging or contrast-enhanced MRI. The management of extraocular muscle injury falls within the domain of an ophthalmologist, but as an ENT specialist, you should know the principles of management. What are the principles of management of rectus injury? You should restore the adductor function, and you should minimize the amount of fibrosis and contractile forces experienced by the antagonizing musculature. The wound exploration is typically done within 3 to 4 weeks. However, if there is muscle entrapment, then immediate wound exploration should be done. The prognosis in this complication remains guarded, so it's very important that you know how to handle the instruments properly. Now, in extraocular muscle injury, the treatment options of medial rectus injury are oblique muscle transposition. You should know the names. Using botulinum toxin to weaken lateral rectus, muscle-to-muscle anastomosis with or without an interposition graft, or hang back adjustable sutures. Okay, so just knowing the names is enough for the theory question. Next, we talk about periorbital emphysema. What is it? It is accumulation of air within and outside orbit. It can happen due to damage to lamina papyracea, which of course can happen if patient blows his or her nose, coughs, sneezes, or vomits postoperatively. Now, management of periorbital emphysema is instructing the patient to avoid blowing nose, and if there is accumulation of discharge within the nose, then instead of blowing the nose, they should suck and spit instead. Sneeze with mouth open. This is also an important instruction that one should tell the patient following endoscopic sinus surgery. If emphysema has already developed, then one should start broad spectrum antibiotics. Usually, periorbital emphysema resolves spontaneously with watchful waiting. The next complication and the final complication that we talk about is optic nerve injury. It is a rare complication of endoscopic sinus surgery, but it remains the most devastating complication of endoscopic sinus surgery because it can lead to blindness. When is optic nerve injury most prone to happen? When Onodi cells are present. Now, Onodi cells may be present in 10% of the population, so it is not very rare. Optic nerve injury can be due to direct trauma to the optic nerve or indirect trauma to the optic nerve in the form of compression, like intraorbital hemorrhage. We have previously discussed the management of intraorbital hemorrhage. Here we will discuss the other methods of treatment. Now, optic nerve injury beyond the entry of central retinal artery may produce changes in the fundus 3 to 4 weeks after the surgery. So immediately after the surgery, patient may have no complaints. The fundus can be absolutely normal, but the symptoms can develop the signs can develop 3 to 4 weeks after the surgery. However, if optic nerve injury has happened within 1 centimeter of globe, it produces immediate findings on the fundus. MRI is a good test to delineate the nerve and the surrounding edema. However, CT scan is of more value in case of a bony spicule impinging on the nerve. So both the investigations, CT and MRI, have their own advantages. Now, what is the management of optic nerve injury? It depends upon the precipitating factor. What is causing the optic nerve injury? There is medical management, high doses of methylprednisolone, that is steroid, with a loading dose of 1 gram intravenous and a maintenance dose of 250 milligram intravenous 6 hourly. If a bony spicule is impinging on the nerve, then the spicule must be removed endoscopically at the earliest possible time. Management of intraorbital hematoma has already been discussed under management of orbital hemorrhage, so I will not repeat that. Optic nerve decompression has the following indications. If the vision fails to improve after 48 to 72 hours of methylprednisolone, if there is progressive visual loss despite steroid therapy, or if there is total blindness with radiological, that is CT evidence of optic nerve compression. Now, optic nerve injury has some prognostic factors like the time elapsed since the trauma until management. So if you don't manage it immediately or as soon as possible, then the chances of recovery are less. And also the degree of visual loss and CT evidence of canalicular or pericanalicular fracture. These are the prognostic factors which influence the chances of recovery following optic nerve injury. So I hope I have been able to answer this question well enough. If you have any uh, complaints, if you think I could have done a better job, if you did not like it, please mention why you did not like it in the comment section below. If you liked it, please tell me which questions I should answer in future videos. I'll be happy to receive recommendations from you. Take care. I hope you like this video and I hope I'll see you again in the next video very, very soon. And to quote my favorite teacher on YouTube, John Green, please don't forget to be awesome.